Hi, in this lecture we're going to talk specifically about synovial joints. So we know that synovial joints are always diarthrotic joints, and that what that means is that they're freely movable and they always have a joint capsule. We're going to look at that structure next. Now remember that over 90% of the joints in your body are synovial joints, and so far we've only learned two fibrous joints. Remember the suture in the skull and the teeth, and then we learned two examples of different cartilaginous joints. Remember, you can have a synchondrosis if it's hyaline cartilage, and you learned a temporary one and a permanent one. Do you remember where the temporary one was? Hopefully you said the growth plate, the epiphyseal plate, because remember that disappears to become the epiphyseal line. And then you had the permanent one, and our example of that was that costal cartilage, right? The hyaline cartilage that connects your ribs to your sternum. Now, we also learned about a symphysis, and a symphysis is a short, thick fibrocartilaginous pad. And there were three examples of those that you learned. So, see if you can say them with me. They were the intervertebral disc in your back, they were the meniscus in your knee, and the pubic symphysis. So most of what we're learning now are all synovial joints. So they always have this joint capsule, and the joint capsule always has four components. So there are four components always found with a synovial joint, and they just kind of go 1, 2, 3, and 4. And again, if you keep an eye on this outline I'm trying to put up here, we're going to talk about the structure first. These are the four main components. We'll talk about some other components in stabilizing, and then we're going to wrap up by classifying synovial joints. So when you're looking at this picture here, you'll see that you have a joint capsule. Now the joint capsule surrounds the entire joint. In this picture, it's been cut from the front, a coronal view, so you can see inside the joint. But the joint capsule goes all the way, it wraps the joint all the way around. And then inside the joint, you can kind of see there's a synovial membrane, which are kind of showing this light blue, and then there's synovial fluid. And then remember, articular cartilage is actually hyaline cartilage, and so they usually color that light blue. So let's talk about this. You have the joint capsule. Articular capsule has two layers to it. It's dense regular connective tissue, and you can kind of see this kind of whitish gray tissue here. So it does have two layers, and the outside thickens to form ligaments. So ligaments are found on synovial joints. And ligaments, remember, connect bone to bone, and all they are extensions of the actual joint capsule, so it makes sense that they're there. Now the inside of that joint, so that fibrous outer layer, is your dense regular tissue, and that's what's going to form your ligaments. Now the inner layer in here is this light purple. The inner layer of that is the synovial membrane, so you can see the purple here. So that's the inner layer of the joint capsule. It makes a fluid called synovial fluid. And synovial fluid is there for several reasons. First of all, it's fairly thick. It should be clear. Colors can indicate problems. If it looks red, that shows bleeding in the joint. If it looks kind of cloudy, yellow and cloudy, that's a classic sign of inflammation within the joint. And so the purpose of the fluid is it helps to lubricate the joint. It provides nutrients to the articular cartilage. Remember, cartilage is avascular, so it's dependent on that synovial fluid. And it also provides a little bit of shock absorption inside the joint. Now, sometimes that fluid, you tear a joint, if you dislocate or you twist or you tear a joint, that fluid accumulates. And so the old terms, I don't think people use them anymore, is like water on the knee, but you can palpate. You'll see a joint swell when there's damage from an increase in synovial fluid, and sometimes you can even palpate it and feel that fluid that's there. So it can increase when you damage and tear the synovial membrane. So the other piece is the articular cartilage. Remember, the articular cartilage lines the ends of the bones. It's there to reduce friction, make a nice smooth glass-like lining here. So it's hyaline cartilage, really important in reducing friction as those ends of bones basically kind of rub against each other when you move. So there's some other components. So those are the four features always found there, okay? Now these are usually there. I don't know why they don't just say that these are there too, but this is how your book classifies it. So just know that a lot of joints have fat, and the fat kind of like the packing peanuts of the body. It kind of fills in spaces and cushions and supports. There's nerves. Have you ever hurt a joint, right? Injured a joint, it hurts. So there's a nerve supply and there's a blood supply to all these synovial joints. Now, as far as some of the stabilizing structures, the first one are the ligaments. So they are part of a synovial joint. We know they connect bone to bone. And we know that ligaments can be considered intrinsic. They're called intrinsic ligaments. They can be extracapsule or intra. So here's the knee joint you might recognize, and you'll see the femur and the fibula, and the femur and the tibia. Let me try that again. So what happens is you have your LCL. And your LCL, remember, connects the femur to the fibula. And then you have your MCL, and that connects the femur to the tibia. Those ligaments are on the outside of the joint, so they're extra capsule. Remember, inside the joint, we had our ACL, and then back there is our PCL, the cruciate, because they crisscross inside the joint. Those are intracapsule. So some ligaments, a lot of them are outside of the joint, but the knee joint in particular has a ligament inside the joint, and that's what those terms mean. Tendons are critical, right? We know that tendons connect muscle to bone. They're going to look white because they have all that dense, regular connective tissue, and so they're very important for stabilizing. So the muscle and the tendons are important for having strong, healthy joints. Now, we also have these little cushions. We have bursa and tendon sheaths. So a bursa is just a little sac filled with synovial fluid, and a tendon sheath surrounds a tendon. So they're very similar, except the bursa is a little sac or cushion, and they're usually found between bones or between bone and skin. So you'll see these. There's one here up here under your chroming process. You have an olecranon bursa right on your elbow. If you palpate that, so if you sit on your elbow a lot, that can get sore. So that's between the olecranon process and your skin. So they're usually between bone and skin or bone and bone, and they're cushions. Decrease friction. Tendon sheaths are really long cylinder-shaped structures, and they surround long tendons. So they're just little sacs of synovial fluid that are really long and surround a tendon. And if you look at your hands, you have a lot of them coming through your wrist up to your fingers and also in your feet. So they're found in the smaller muscles and smaller tendons, especially in your wrist and feet. Now, when we're looking at classification here, on the bottom of your page, there's a little blip here about synovial joints and types of levers. And I'm not going to go through the whole lever. If you're into kinesiology, it's fascinating. It's really kind of cool. You can get an idea of why people that are short and stocky are going to be stronger and more powerful than people who are long and lanky. But I don't want to digress too much. So just understand that the way the joint works is it all comes back to levers. So if you like physics. And so the joint is always going to be a fulcrum. And then the muscle attaches usually distal to the joint, not always, but for the main ones we're using. And then we have a force. And so what happens is the bone kind of works like a lever, and the muscles supply the force. So most of the muscles in the body, this is called a third class lever. And this is how most of them work. FYI, if the lever is really long, right? If the bone is really long, you're going to have a greater range of motion, but it's a lot harder to lift it. Think about if you're trying to lift a rock, you're going to shove a stick under it, but you're not going to shove a 20-foot long stick, maybe like a 6-foot long stick. So when we have shorter load arms, basically, we're able to move more weight. And so some of your ability to lift weights and your strength is really based on your body. Do you have long load arms, long levers, or do you have shorter ones? Now, based on that kind of idea, we have a functional classification of joints, and you've seen these words before. So they can be non-axial, which means they don't actually move, they just kind of move side to side or glide. But if you have an axis, it's an axis of rotation. So uniaxial means it has one axis to rotate on. So they're pretty straightforward. If I had an axis through my elbow, I'm pivoting, right? I'm moving around that one axis. Biaxial is going to have two movements, two different planes of movement. And you can call it triaxial or multiaxial. Those are the most movement, and that kind of makes sense. So here's a picture just kind of showing you some of the joints that we've studied and some words you're going to see that you've seen some of these already. So the joints have a name like ball and socket, hinge, pivot. That's the name of the joint. So the location of the joint would be elbow. Shoulder, that's joint location. Name of joint, hinge joint, condyloid, these are all names. Type of movement is uniaxial or biaxial or triaxial. So we're going to go through by movement and look at the non-axial joints first. So they're called non-axial, and the name of the joint would be a gliding or plane. Either one's fine because the bones just move slightly, not a lot, and there's a little bit of movement between bones. These are the examples of the intercarpal and intertarsal joints. So again, joint name, gliding or plane. Location in the body, intercarpal, intertarsal, or SI joint. Type of movement, non-axial. Okay. The SI joint, again, is going to connect the sacrum to the ilium. And again, that has a little bit of movement, but not a lot. Okay, uniaxial joint, so movement, uniaxial, one axis of movement. So name of joints, examples are hinge joints, are uniaxial, and so are pivot joints. Where do you find hinge joints in the body? The elbow and the knee. And remember that the movement at the elbow is just flexion and extension. It's just a hinge. Remember how that trochlear notch fit on the trochlea and just moves, okay? Now, a pivot joint has two examples. One of these we haven't talked about yet, the atlas on the axis. You may know that your first cervical vertebra, so we'll say C1, is called the atlas, and the second one is called C2. And so C2 has this little piece of bone that sticks up, and C1 sits on it, and it pivots. So when you turn your head no, the reason you're doing that is because the atlas pivots on the axis. So you can see how that's a pivot. The one that you've seen is the proximal radial ulnar joint or proximal radius ulnar joint. And remember, that's the one that we use to supinate or pronate because the head of the radius pivots and that little radial notch of the ulna. Okay, biaxial. So the name of the joint is called condyloid. Ellipsoid is an older term. You'll hear condyloid. So these have more than one plane of movement. Now, again, we haven't done the head and neck yet, but a really good example is if you look at the skull, there's these little things called occipital condyles on the bottom of your occipital bone. And then C1 is the atlas. It has a little place for them to meet. So these condyles can rock this way or this way. Okay, so what does that look like? When you shake your head yes, you're just rocking them this way. And then when you do lateral flexion, remember we talked about that, it's rocking it this way. So I have two axes of movements between my occipital condyles and C1, or you can see the atlas. Another example are your knuckles. They're called metacarpal phalangeal joints. It's a long word. I don't really ever have you write that. But technically they're a condyloid joint. And then the one that you all know is triaxial. These are triaxial or multi-axial, the classic ball and socket, right? You got the head of the humerus or the head of the femur. Head of the femur sits right inside that deep socket, that acetabulum. Head of the humerus fits into that glenoid fossa. And so what happens is, again, you have multiple movements. So we have flexion and extension. We have abduction and adduction, and we have rotation. And so our triaxial joints are going to be the most movable joints. So the name of the joint, ball and socket joint. Example in the human body, shoulder and hip. Type of movement, triaxial. So that concludes. We've just finished up our classification and information on synovial joints.